All right. What's up, everybody? So we'll go ahead and get started with all the normal logistics and as people roll in. So if you're not new or if you're not familiar with Clinical Athlete and this is your first journal club, welcome. You've got a few options as far as participating. You can type. So in the chat here, we want to make this interactive. So just because I'm leading it doesn't mean that I'm not coming in here wanting to learn just like you guys. So I just happen to have the Zoom login. So I open the show, but I want this to be an interactive conversation. I want to learn from you guys as well. So if you have a question and you want to just have it read out loud and have us discuss it, then you can type the question into the chat. But if you want to actually unmute yourself and talk, like we're having a discussion amongst a small group, then you can type the word question before your actual question, and that will prompt us to tell you to unmute yourself and to go ahead and ask. And Megan, our Clinical Athlete Journal Club intern, put that prompt into the chat, so you can look at that just for a reminder. But feel free to interact. We want this to be as interactive as possible. Or if you just want to listen and soak up the conversation as an active listener, you can do that too. We will also do breakouts like we did the last couple meetings, and we'll do that towards the middle to latter half of the conversation so that we can have more intimate groups and you guys can talk amongst yourselves. These meetings are open to anyone that want to join in. So when we do these, once a week or so, you can tell your friends and that they can join in, and you don't have to be a member of the forum or anything like that, but we do put the recordings in the forum. Now, anybody who registers for these meetings will get the recording sent to them, and you'll have 7 days to check it out. So there is that. And then the recording will go into the forum. So if you're interested in the forum, which is kind of our hub of education in regards to athlete health and performance, I just put an application link in the chat. And I'm also going to link the paper that we're going to go over tonight. So that second link, that Adobe link, will take you right to the PDF. So you can download the PDF if you hadn't gotten to it already. And then just a quick note on sound. If you are unmuted and you join the conversation and then later on you're not speaking, just try to be cognizant of your background noise, and better yet, try to mute yourself again if you're not talking. That way any background noise doesn't come in to the broadcast. And then otherwise, feel free to use the chat as a kind of a live discussion, side discussions as we're having the journal club here. My usual partner in crime, Kevin McNamara, fell ill tonight, and he won't be joining us. So if you think of it, send him like a get well gif on Instagram or something. But my name is Quinn Hennick, and I am a physical therapist in Southern California and a proud clinical athlete provider. And we are joined, as I mentioned earlier, by our Clinical Athlete Journal Club intern, Megan Broussard, who is a student PT down in Texas at UT Southwestern. Say hi to the people, Megan.
Oh, gotta unmute myself. Hey guys.
That's the trick, see? Megan's gonna help us curate your guys' questions, so we'll try to keep things organized. And if you're curious about the motivation for these meetings, way back in the day, a smart guy named Benjamin Franklin started a weekly club. It was called the Junto Club. And it was basically a mutual improvement club, but it was a bunch of really smart people just gathered around the same room discussing issues and topics of the day, kind of like this. And they had an important policy for their meetings, and we've adopted that policy for the Clinical Athlete Journal Club. And that is that these meetings are conducted in the sincere spirit of inquiry, after truth, without fondness of dispute or desire of victory. So we welcome healthy discussion, but we're all on the same team, and we're all just trying to be less wrong. So tonight's journal club number 28, is the topic is risk factors of overuse shoulder injuries in overhead athletes. And that is a systematic review that we're going to be discussing. But before we do that, I want to launch a quick poll that Megan made, just kind of getting a feel for the room. So you should have a question that popped up in front of you. Are you a clinician? Are you a student clinician? Are you a coach? or a trainer or a student coach trainer, just to get an idea of who we got tonight. Give you a few seconds to answer that. And then we still need a scribe, Megan says in the chat. So if you take notes for these meetings anyway, feel free to send us those and we put them in the forum so people can follow along. Doesn't have to be anything crazy. Okay, so it looks like we've got a lot of students tonight. I'll go ahead and share that with you guys. Nice. I think this may be one of the first times the student clinicians have outnumbered the clinicians. And we got some coaches and student coaches. Awesome. Okay, so the paper that we're going to be talking about, and we jump in assuming that you guys have read the paper, but if not, no big deal. You can download the paper through the link that I put in the chat and you can follow along and then you can read it later. But the title of the paper is Risk Factors of Overuse Shoulder Injuries in Overhead Athletes, a Systematic Review. And the lead author here is Camille Tooth, and this was published earlier this year in the Sports Health Journal. And I'm just going to kind of give a brief rundown. So for those of you who have read the paper and you already have thoughts, start putting some of your thoughts in the chat already. And that way, when I get done with my little rundown of the paper, we can get the conversation going too. Because again, I don't want this just to be me talking at you guys. But this was a systematic review, and their question was, the purpose of this systematic review was to identify risk factors of overuse shoulder injury in overhead athletes. So that's the question that they're looking to answer. And it's a systematic review because they use a systematic process to aggregate a bunch of studies that help to answer that question. And they use the PRISMA guidelines, which is super solid, the preferred reporting items for systematic reviews and meta-analyses. That's a checklist that you can get. Just Google PRISMA and you can kind of check that out. But it's definitely one of the preferred methods for formulating a systematic review. So they use that. And they had specific inclusion and exclusion criteria that you can check out in the paper, but they were looking for studies where at least the papers describe at least one possible risk factor associated with shoulder injuries in overhead sports specifically. And that was volleyball, handball, basketball, swimming, water polo, baseball, badminton, tennis. And I was looking at those sports, and basketball, I don't always consider an overhead sport, but I guess every time you shoot, block, rebound, so it makes sense. Only prospective studies were included. So studies where they take a group and they measure stuff, and then they observe the group, in real time, and then they follow up. And that's a good study design to identify risk factors within a population. So that was good. And they excluded any studies that were looking at other body parts. They excluded the traumatic injuries or contact injuries that wouldn't be explained by any other risk factor other than they got hit. They excluded any surgical procedures. So you guys can kind of check that out. So that's the bandwidth that we're looking for. And yeah, Paul says, and dunk. That's why. So I never had that problem. All I did one time, dunked a women's basketball off of an alley-oop. It happened one time. I could not ever recreate it again. Paul is what we learned in the Journal Club with Chris Hewen, is Paul is 6'8" and he played collegiate basketball. So he could probably dunk on all of us. Vince, right. This was like when I was 18, man. I don't think phones had cameras on when 15 years ago. Okay. Sorry. Studies. So that was the question, and that was the groundwork. And they ended up with 25 studies, and they were looking at, started with like 3,000, whittled it down, and they ended up at 25 studies, 11 for baseball, 6 for handball, 3 for swimming, 2 for volleyball, 1 for tennis, and 1 for basketball. And you can check out in table 1 where they kind of aggregated all of the studies and described what they pulled from each study. And I know that the tables are turned, but you can see the study, they labeled them by sport, by the number and type of, by the incidence of injury, the materials that they use to measure the risk factors. So if the risk factor that they identified was, say, external rotation strength, they say, oh, we measured that with a handheld goniometer, or we measured that with an isokinetic dynamometer. Range of motion, if that was a risk factor that they identified, oh, measured that with a bubble goni or a handheld goni or whatever, digital goni. So you can see that in table 1, and the length of tracking, from less than a season all the way up to 8 seasons, 10 seasons, and then the quality of each particular study. So, and then in table 2 is where they kind of give plus minuses in regards to these groups of studies looked at this particular risk factor and gave it, yes, it's a risk factor with a plus sign, or no, it didn't seem to be a risk factor within this study as a minus sign. And so table 2 starts on page 8. And as we go through, obviously some of these are modifiable and non-modifiable. A history of shoulder pain and with or without shoulder injury seems to be a risk factor, but that kind of goes along with the old adage, and that's supported, that previous injury, previous pain is a risk factor, and that goes for most areas of the body. And obviously that's non-modifiable for most of us, as they're already coming in with a problem. So we're dealing with it retroactively in that case, but it's something to consider. Range of motion seemed to be somewhat equivocal. So, and this is hopefully what anybody in this group that's more versed in these papers can talk about, but especially with baseball, we would thought that GERD, goniohumeral internal rotation deficit in a baseball player, what you'll see is a surplus of external rotation on the throwing side, and then seemingly a deficit of internal rotation on the throwing side that can kind of fluctuate throughout the season. And the early studies were looking at just from neutral, external rotation from neutral, internal rotation from neutral. And then they were seeing that there were changes in internal rotation, range of motion on the throwing side. And then, later on, as the research progressed, they started looking at the overall humeral arc. So they started to see that, well, the actual arc of motion is the same from side to side. They're just getting at it from different starting points because of these adaptations that are occurring from years and years of throwing, not just soft tissue, but also humeral torsion. The bones are actually changing from years and years of throwing. So they said, okay, if the humeral arc is the same from side to side, even though they have an apparent internal rotation deficit, if you start them at quote unquote neutral, then it's less of a risk factor. But you see, some of these studies are equivocal, showing range of motion is a risk factor and some showing that they're not. Muscle weakness imbalances looks like kind of across the board, there may be something there, but hopefully we can kind of talk about this. If you pull all of these studies, they're measuring different things. Some of these studies are measuring the difference in external rotation strength on the throwing side compared to external rotation strength on the non-throwing side. Some of them are comparing external rotation strength and internal rotation strength on the same side as a ratio. And some studies will say, oh, this ratio seems to be a risk factor. And some studies will say, oh, that's not a risk factor. It's external rotation from side to side. So it's not just, I kind of want to throw this out there, that table 2, it's not these pretty plus or minus signs. Oh, strength, risk factor. There's a little bit more nuance there as you pull the papers, but at least this does say, oh, plus, 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 there may be something here. Let me dig into these papers a little bit more closely to see if this kind of applies to the population, number one, that I see, and then 2, can I measure the same things that they measured in those studies to make it clinically relevant for me? Scapular dyskinesis, always a fun one. Maybe not. And so that's something that we can have a conversation about. Years of practice didn't seem to be all that much of an issue in 2 out of the 3 studies. Body mass index, maybe. Different sports, like maybe it's a problem in basketball more so than it is in baseball. But then what's the relevance for the shoulder? And that, I think, is a good point to bring up, is that a risk factor doesn't also mean that thing causes the problem. It could, but association, as in an associated risk factor, it does not imply or infer causation. That requires another study. So what you would do is you would look at this and say, this seems to be a risk factor consistently in the literature. Let's do some type of randomized prospective trial and try to tease that out a little bit to infer causation. But one of the famous associations in the world is an increase in shark attacks is associated with an increase in ice cream sales, to the point where they can predict one another. That's how strong of an association there is. Well, let's think about that. Do ice cream sales cause shark attacks? Probably not. Do shark attacks cause ice cream sales? No, probably not. Is there a moderator in the middle? Well, during the summertime, there's probably more people in the water and more people buy ice cream. Okay, so weather. So there's moderating factors that we may even not think of. So keep that in mind when you're looking at this. Just because the shoulder weakness is a risk factor doesn't mean that then strengthening the shoulder is going to make a dent in the injury incidents. It might, but it doesn't necessarily mean that's the case. So just keep that in mind. And then training load. Field position was an interesting one. Seemed to matter, but what are you going to do? Change their field position? But training load seemed to matter. And a lot of those studies are coming from pitch counts for baseball players. Megan, you want to read Alex's question? That's pretty much the gist of what I had to say.
Yeah. So Alex asked, in isolation, does the presence of any one or more of the risk factors mentioned in this article concern you enough to warrant intervention, if modifiable, from an injury risk reduction standpoint?
Well, maybe. I think that's just a call that you'd have to make as a clinician. So another point here is that this was not a meta-analysis. So they didn't then take the results and the data from each study and pool them so that we could see pooled effect sizes. The reason they couldn't do that is because if you read the paper, they've mentioned several times the heterogeneity of the studies. I mean, it's pretty insane. So all of those sports, different types of athletes, they reported injury incidents differently. So if you look at table 1, some of the studies reported injury incidents as just number of injuries divided by number of the players. Other studies used exposure. So number of injuries per 1,000 hours of exposure, which is a more progressive way to report incidents, because how do you compare athletes to athletes if some athletes have different exposure rates to the sport? Like if somebody just sits on the bench for all the games and then somebody else plays most of all the games and all the practices, it's not an apples to apples comparison. So now not only are we trying to compare across different sports, we're trying to then compare different ways that they even calculated incidence. So it becomes very difficult to pool the data. And then even within strength measures. So a lot of these studies, more than one study, showed that strength was a risk factor, but they measured it differently. Some measured it with an isokinetic dynamometer. Some measured it with a handheld dynamometer. Same with range of motion. If you use a bubble inclinometer versus a digital versus a standard GONI, those all have different standard errors of measurement. So you can't pool this data. And that's basically, they just did us a favor and aggregated all these papers so that we could do our own research. I mean, that's really basically what this is. They said, here's what all the papers showed, make your own conclusions. So Alex, I think there's enough literature on training load and muscle weakness to at least dig into those papers and make a decision as to if it's something that you want to assess. If the prone IR test, if you have a handheld dynamometer and you want to standardize that as a test, even if it's just return to play after an injury, I think there's something there to warrant. But something else I wanted to bring up was, in their discussion, they kind of just pontificate about why these things are risk factors, what you can do about them. I mean, none of this stuff is rooted in solid evidence right now, to be honest. And I want to show you guys one of the papers that they referenced as a injury reduction program. And I'm going to share my screen because I pulled the paper and it shows all the exercises. Share screen. Okay. So it was this one. No, it wasn't. It was this one. So here's the program. Now this paper, Preventing Overuse Shoulder Injuries Among Throwing Athletes, cluster randomized controlled trial and 660 handball players. So this was a paper that they referenced in the discussion. And what they found was not crazy numbers, but anywhere from 5 to 8% decrease in shoulder issues, shoulder injuries from the group that did the exercise program as a warm-up to the group that didn't. And this was the program right here. And to me, this looks a lot like the equivalent of the FIFA 11 that football, soccer players will do as warm-ups. That's just a conglomeration of a bunch of decent, exercises that are probably just generally good. It looks a lot to me like the ACL injury prevention programs, literally hundreds of them out there that all have similar components, but then different components. Some have no what you would consider strength, and it's all like balance training. And some have more of what you would consider strength. And what's funny is they all seem to have somewhat of a positive effect. It's like, if you just get these athletes who a lot of them don't do much outside of their sport and just get them doing different things, there seems to be an effect. But I mean, there's no magic to these exercises. So they didn't look at these exercises prospectively and say, oh, these exercises individually decrease risk of injury. No, they just threw a bunch of stuff that made sense to them because they said, okay, baseball players tend to have internal rotation deficits. Let's throw in the sleeper stretch, which makes me cringe, by the way. But I like when I was like a first year out of school, I feel like I jacked somebody's shoulder up having them crank into internal rotation. I've never prescribed that ever again. I just have somebody hold a weight and it's active. But anyway, same deal. Thoracic extension sounds like a good idea. Well, let's put a little weight to it. So they do this ball thing. ER strength, again, in the tooth paper, shown to be a risk factor or potentially right here. A lot of these are looking at ER strength. So what do? They make up an exercise that say, oh, this would help with deceleration and probably affect the external rotators. And then this exercise here, that's kind of like a slider push-up that would engage the scapula and probably, engage the serratus and the upward rotators and everything else that's involved in holding your shoulder in that position. And then if these athletes do all these things as a warm-up over the course of many weeks, on average, that group seems to have less injuries. And we have no clue as to why. And I'm not sure in this paper they even measured, I'm sure that they did. They have other outcomes other than injury. I would think that they measured to see if this program is even having an effect on different biomarkers like strength. I don't know how you measure, neuromuscular control of the scapula, but this is a paper that you'd want to dig into, Or another option is just take it at face value and say, you know what, doesn't matter. I could just take this set of exercises. It's easy to implement into anybody's warm up. Just do it. I mean, what's the risk? Okay, stop sharing my screen.
Kind of going off of your exercise thing, Nicholas asked why the emphasis and the conclusion on eccentric and concentric for external rotators, but only eccentric for internal rotators.
I don't know. That's my answer, Nick. I don't know. I missed that. I usually see an emphasis for external rotation eccentrics because that's kind of the deceleration component of a throw. But so those questions, I think, Nicholas, what you would do is you would pull the individual studies. And that's the benefit of a paper like this, is at least it aggregates those things for you. So if you have those questions, it'd be like, okay, what do they actually look like? Because the authors of this paper are really just looking to give you a very, very brief overview. But that's a good question. I'm not sure.
Thank you.
You're welcome. Oh yeah, we're supposed to be unmuting them. Megan, I blame you.
Oops, sorry. Kendall, do you want to ask your question?
She didn't write question.
That's okay.
Oh,
I was actually jumping in on the last question that was kind of posed. Why not strengthen the concentric internal rotator? If you did that, wouldn't that just reinforce the altered strength ratio between the two? Because the internal rotators are stronger than external, so just strengthen them in eccentric rather than concentric. That's just what I was thinking there. Sorry.
Yeah, maybe. So if the way, I'll pull up another paper too. So if you guys are curious about how they typically measure, so that's a really good point, Kendall. I think a lot of those conclusions, I think that's probably one of the reasons they do stuff like that, but it's more, that type of stuff is more kind of clinical judgment. You know, you would think it just kind of makes sense. Okay, well, we test them this way. So a lot of times they're not actually testing eccentric, they're testing isometrically, especially if they look at a handheld dynamometer. I'll share my screen. So this was a paper that the tooth group referenced, and this was one of the shoulder strength papers that they put that got a plus on it. And this was preseason shoulder strength measurements in pro baseball players, identifying risk factors. And what they found, so now you have some norms and some data to go off of, but this is how they measured ER and IR in this position. And they use a make test, which means they had, so if this is the dynamometer right here, my fist, they had the person push as hard as they could into the dynamometer. We call that a make test. If it was a break test, the assessor would actually win. They would try to win. So a break test is always typically more force is generated because you're literally pushing the person to the breaking point. But it can be more uncomfortable. There's more noise associated with the test because now you're moving. And so a make test tends to be more repeatable, more reliable, and a little bit more comfortable, especially if a person is already injured. And that wasn't the case in these studies. They're pain-free because it's prospective, but it's not actually eccentric because it's just, they're not pushing eccentrically, they're just pushing isometrically, but that's how they measured it. And in this study, what they found was that ER-IR ratio wasn't a risk factor, but ER strength from side to side was. And the number wasn't all that big. It was like, if you had a 5% deficit with a standard deviation of about 10%. So, which is funny because that takes you over having a deficit. But if you're at, 85 to 95% from your throwing arm to the opposite arm, or said another way, 10 to 15% deficit, that was found to be a risk factor. But that was ER strength to ER strength, not ER to IR, where other studies have found ER to IR. So you've got to think maybe that's just science noise, or maybe it's population specific. Did they measure some papers measure this in supine? Does that matter? So some measure it with an isokinetic dynamometer. So again, there's a lot of differences. I think low hanging fruit clinically, if you have a handheld dynamometer, this is a very easy test. And whether you do it in supine or prone, just do it the same way each time. And it at least gives you a little bit of prior data to work off of. I'll stop sharing. We got questions.
Yes. So Ryan, you do not want to unmute. Okay.
He's eating dinner. No.
Yeah. Okay. So he says, at what point is a prevention strengthening program overloading the tissues and possibly increasing the risk for injury? How do we know when it might be too much? And is there a possible downfall to mimicking overhead activities in off-season strength and conditioning as far as year-round overuse goes?
I would love to get everybody's thoughts on this because it's a really good question. I'm generally conservative when it comes to sporting athletes, whereas the training, the gym training itself is not the sport, it's a means to an end. I look at the gym and these types of training modalities as protecting from the downside we clean that up first. And then if we want to nudge the ceiling or push the good side, try to push performance markers in the gym to then transfer, we pick our battles. But another way of saying this is I think about it like I'm pulling their floor up as opposed to trying to push their ceiling. Pull the floor. And so it's a conservative approach. So then to your question, what is it that they're not getting in their non-sport training that I could potentially supplement with? And so like that program, by the way, the name of that shoulder program that I showed you guys is called ready for this? The Oslo Sports Trauma Research Center Shoulder Injury Prevention Program. So the Ostrich program, let's say they're a basketball player who just doesn't get a whole lot of weight room time for whatever reason, various reasons, or baseball, whatever. You're throwing a program like that in as a warm up because they're just not getting anything other than their sport. But what if it's an athlete who's got a super solid strength conditioning program, like the coach, and they're doing awesome? Do you think that those set of exercises are going to add any benefit other than just adding more? It might be a good warm up. I think programs like that, there's really not a whole lot of harm. Like if you looked at those exercises, there's a ceiling effect to that stuff. Like it's going to, at some point for an athlete, it's going to end up just being like easy. And at that point you've probably capped out, and that's just literally a warm up. So I certainly do think that there is a such thing as just piling on more and more for the sake of doing more. That's not actually beneficial. But I try to think of it as, what can I give them that they're not getting otherwise? And I don't know, so you can follow up with that if you have more to that, but it's a great question. Let's do, I say we break out. Okay, so we always lose a few people, and that's okay. I know some of you can't turn your camera on, you got other stuff going on, you just want to listen. You can also just do that. But if you're going to drop off the call, go ahead and do that now. I don't want to sound mean, but just so the numbers are even. And I'm going to put the prompts in the chat. So this is going to be what you're working off of. These are questions. There's 3 of them. Okay. I'm waiting for people we lost 10, just like that. Bam. Okay, good. Here we go. So look at those questions. I want you to talk, amongst yourselves, come back with some thoughts, and then we'll reconvene. All right. Cool. So we're back. Megan, I'm going to put you on the spot. Was there any awesomeness happening in your group? What'd you guys talk about? And then while she is kind of going over what her group talked about, if any of you guys have some thoughts from your group that you'd like to share, throw it in the chat.
Yeah, so we spent a lot of time on the first point and didn't get much into the rest, but we had, I think, different views as far as worrying more about, posterior capsule tightness and working on range of motion, or do you work more on like stretching external rotators? And then is it more position dependent? Because I know, like Derek was saying, as an athletic trainer who worked with pitchers a lot, they tend to like play, and then they're very protective of their shoulder and they don't really want to do anything else because that's their livelihood. And so we kind of had a lot of discussion in that respect, I guess.
And so maybe, I don't know if this is what maybe Derek can chime in, but so compliance could be something that you look at too. So like,
yeah, or like the psychological aspect of
doing more.
Yeah.
No, that's huge. I also think that's why some of these programs, like the one that I showed you from that paper, they're not like super intensive, a lot of times because of that reason. These athletes don't like, a lot of them, I shouldn't say all of them, but a lot of them don't like the gym. They don't like anything other than doing the sport. And then those that do maybe don't like the exercises in these programs, but what they are is they're low hanging fruit. They're not super stressful. So maybe it's just for the pitcher, just getting your shoulder to move a little bit under some heavier load instead of really high velocity. But whether that's good or bad, when you've got a pitcher who just threw, 110 pitches and just needs to chill. So I don't have an answer. I think maybe that's why they try to throw them in during the warmups. Like in that study specifically, that whole program was done during the warm-up before practice. So at least you get it in, then you can practice and then do whatever you do. But that's good stuff.
Just real quickly, as far as like looking at the intrinsic risk factors and kind of going through where there's some positive and negative like discrepancies, I guess. And then if you go back and look at the quality of the study that it came from, how much weight are you putting on, I guess, the quality score that was given by the authors?
I think you put weight to it. That scoring system I hadn't seen before. So, I would be lying if I said I dug into all of the different scoring criteria that these systematic reviews use to appraise these studies. And you take it at face value to some extent, but it didn't seem like the quality was very high in most of these papers. So you do take that into account, but you also take the totality of the evidence as a whole. And so this is a question that I don't know if it has a right answer, but if the aggregate of moderate quality studies is pointing or leaning to a certain direction, is that enough evidence to shift my prior in that direction? And also, systematic reviews are limited to their inclusion and exclusion criteria. So these are not all of the papers looking at a question similar to this. It happens to be the papers that fit their inclusion and exclusion criteria, which they made up. So you might find different systematic reviews include different papers that were not part of this paper that add to the totality of the evidence. So that's what you got to look at, is of the quality of the individual studies, but also the totality of the evidence. And so that, I don't have a right or wrong yes or no answer, but that's what you're weighing. But I certainly make note that we're not looking at like super high quality stuff here, at least from their scoring criteria. And like I said, that one paper that I pulled that looked at, it showed a difference between this side and that side, and that was a risk factor, statistically significant. It was like a 5% difference. So you might ask yourself, if you're measuring with a handheld goniometer and that person is not anchored to the table, you might be measuring error. I mean, that might not be surpassing the standard error of the measurement. So it's for sure something to consider.
And we have a few comments in the chat. Jason says, one thing our group touched on regarding the discrepancy between risk factors, common with black box studies where the mechanism of injury isn't actually known. Relationships between variables or moderators create that discrepancy.
So I think, yeah, that's a really good point. And I think it goes into what we were talking about with the ice cream sales and the shark attacks, where you were only looking at association, but you're not actually looking at the black box. And Jason can chime in if I'm not describing what he's saying correctly, but the black box being, we just know there's an association based on our statistical model. We don't know why. And so that's what a lot of these studies are showing. And I think that's a really good point. So what you haven't heard me or anybody else say is that external rotation shoulder strength causes these injuries, because that's not what these studies are looking at. Or at least that's not the question that this systematic review is trying to ask. They're looking at associations.
I had a question.
Yeah.
So like currently I have like a 13-year-old kid, and he's got some shoulder pain from pitching. And so I did like handheld dynamometry today, and he had like 25 pounds on his right side, and on his left side, which is throwing arm, he had like 16 pounds. And so like in my head, I was thinking, oh, well, I found the problem. It's the external rotation strength. But, and I started thinking today, well, does he have external rotation strength deficits because his shoulder's painful? And so like, to what extent is the correlation more so like these people have an injured upper extremity, so they're performing lower on a handheld dynamometer? You know, that's kind of what the thought that I got to today with that.
Yeah. No, totally. And also that was something I hadn't mentioned with these papers. Pain in at least one of the papers, pain was the risk factor that they looked at, which means that they were looking at population with pain. And in a lot of these other studies in the same paper, these are healthy populations. So that again, we're comparing across groups, and it's just very difficult to do. But yeah, Ben, you know, the directional arrow, where's it headed? So to me, clinically, we could pontificate a little bit. So potentially we could say what you measured was tolerance. Now, if you could take two measurements potentially, you could take force to pain. So the amount of force that creates the symptoms, if that's some type of concordant sign. And then you could say, if you're comfortable, I want you to tell me when you start to feel your thing. And you could note that degree of force that they're able to generate in that time point. And you say that's time to pain or force to pain. And that's a proxy for the tolerance in the position. And then you could say, if you're comfortable, I want you to push as hard as you can beyond that to your comfort level. And then that's their current capacity, which is going to be affected by pain 100%. So it's just more noise, but it doesn't mean that is necessarily not useful information, because it gives you at least a baseline, and it gives you guys a talking point. And at minimum, you did something that seems like a fancy test, and you probably got some buy-in because you had this fancy thing called a dynamometer or whatever you told him, and he couldn't remember the name. But you've got a number now that you can gauge progress. You can say, hey, you know, over time, at least your tolerance has gone up, because remember that, you know, you were testing and you only put in, it was 10 pounds of foot-pounds of force before you started to feel your thing, you know, and now it's 16, but peak stayed the same. So maybe in your mind, you're thinking, okay, well, maybe now it's a capacity thing that we can push the ceiling on a little bit. But you might also find that when the pain cleans up, strength comes, and then it's the same. So I'm not sure how much it changes, but I'm also not going to say it's not useful information to at least give yourself kind of a starting point. Does that make any sense or help at all? Yeah.
Yeah. Thank you.
That's the next comment. Caroline says, something that always is conflicting to me is whether to stretch into internal rotation after activity or use that measure to assess how fatigued the shoulder is the next day, and work in that actively with eccentric exercises to ensure they're able to control the increased mobility.
Who asked that?
Caroline.
Okay. Sorry. I was, yeah. So some of these papers are showing a change in range of motion. It kind of goes back to what Derek was saying, where you might see the athlete kind of protecting that shoulder, but then if you actually measured, you may see a change in range of motion. I tend to not crank it, and to kind of see, you know, how that 24-hour window after the activity, if things start to normalize, or just some general exercises, like again, in that paper, it's not like specific, except for the sleeper stretch, except for everything else is just kind of very general shoulder stuff. You know, it's kind of those fluffy exercises that may just kind of feel good and get things moving again, when there wasn't anything structurally stuck. But I tend not to have them crank into positions that are a bit guarded, because they, you know, may be guarded for a reason. You know, maybe that's the body's response to the stress, and it just kind of needs to hang out. Now you guys might say, well, if it's just kind of a very gentle, just kind of coaxing the range of motion back, just so they can get that back as soon as possible. Yeah, I think there's something to that. But yeah, I'm not sure. And if you have thoughts to add on that, Caroline, or anybody, happy to discuss.
Nicholas, do you want to unmute yourself?
Sure. So my question is, so this is something that's been like a little controversial in the literature and also in the some courses I've taken, but like, can we actually, so if this whole purpose is about kind of load monitoring, injury prevention / rehabilitation, I guess the big question also boils down to, are we yet able to accurately predict injury in overhead sport or injury risk? So can I say, like, my outside hitter for volleyball, because I'm currently working with volleyball for strength conditioning, hits X amount of balls, they are at an increased risk of getting injured here? I know it's a complicated question, so feel free to.
Oh, well, I mean, it's the question. So there's so much there. First of all, these studies generally, this is my take, and I'm happy for anybody else's take on this, but these studies are looking at the group averages. So you determine associations and you determine risk factors. To some extent, you're able to predict the group incidence. But what you're asking is about the individual. And that's what we care about from a clinical standpoint. And that's where we're not from a modeling standpoint. And even if we were, like, you increase your risk every time you step out onto the playing field. First of all, exposure is risk, right? If you don't want to guarantee you don't get hurt, stay home. At least you won't get hurt doing this sport. But what if we have this fancy statistical model that is able to take an individual based approach and say, based on these moderators, your current sleep habits, because we're tracking that, your current nutrition habits, because we're tracking that, and you're honest about it, your current training load, all of these things we're aggregating, and you have a 27% risk of injury going to this game where your average is only 8%. We'll say 24%. So you're now at a threefold increase for injury. Couple thoughts. You're still only at 24%. You're 76% likely not to get hurt. So there's that. Number two, you're going to hold people out. What's riding on this? That's the big ethical question. Do you tell them? Do you say, hey, this is your choice to play, but just so you know, your risk of injury has gone from 8% to 24%. And then you walk out the door, you walk out the locker room, and it's like, do you want to plant that seed in their head? So, man, there's so many questions. We're not there. I mean, these group-based data give us a starting point, and they tell us, well, maybe we've got some tests that we can check out and we can start to tick some boxes. And we know we can't predict really all that well, and we can't prevent on an individual level. But if we tick some of these just general boxes, at least we're doing what we can with what we know, which is very little. But if they've got generally solid, IR, ER strength from side to side, and they've got normal, or they've got symmetrical humeral arc, it's going to look different for a pitcher. But you say, okay, at least I ticked that box off. I ticked that box off, and now we can talk about pitch count, and we can talk about sleep and talk about nutrition. You just start ticking off these boxes as you go along. But to your question, we're not there. And even if we were, I just can't even imagine what that would look like from I know it's a non-answer, but hopefully that was somewhat helpful.
Yeah, it was. Thank you.
Yeah. I guess I'll say this. If we had the shoulder, we're not quite there, but if we have incidence data and we have tests with likelihood ratios, if we have prevalence data, so we have a prior probability, if we have tests with a certain likelihood ratio that can take us to a post-test probability, if it's something that's increased to a degree that we think is significant enough to make a difference, it's an ethical question to keep that in regards to talking to the athlete, him or herself, or even talking to the sporting coaches, their athletic training staff, or whatever, depending on what setting we're in. So I don't have the answer, but these are questions that are important to ask. It's not just, well, they're probably not going to get hurt and I don't want to nocebo this person, so I'm going to keep it in. So it's just the stuff that we deal with, that we're dealing with as clinicians. And we could probably talk about specific cases, and there would be a lot of half the room would have done one thing and half the room would have done another, you know? Thanks for bringing it up, though.
Last comment, Derek said there was a blog looking at scapular dyskinesis that there was more dysfunction as they continued to exercise. The longer they exercised, the more they saw changes in function. But after 24 hours, they resorted back to normal.
I haven't read the blog, Derek, I'm not sure if I've read that study, but I mean, it makes some sense to me. That would just be like the shoulder is fatiguing. And so you're getting some, I mean, we've all seen wonky ass shoulder blades. It's not that a scapula can't do odd things. It's that it doesn't matter. Can we do anything about it? But that would make sense to me, as it's just kind of the system is fatiguing. I wonder if you would see, in fact, I know this, at least one paper looking at humeral translation as somebody fatigues, like during a lateral raise, and as the rotator cuff fatigues, you see increased migration superiorly of the rotator cuff. And some people will, make the argument that increases risk of impingement. Well, I mean, physiologically, biomechanically, that's what it's doing, but it's just training. But my point there being, fatigue can change kinematics and kinetics, and it's kind of that coupled relationship. So that doesn't surprise me at all. I wonder if, with continued training, could you train? First of all, we have to come to an agreement that increase in dysfunction would matter from a performance perspective. Like, is that shoulder less apt to produce and absorb load as it fatigued, and as that system becomes destabilized? But then could you train that system so that you prolong the time period before the dysfunction grows, stuff like that. So I don't know, but.
Another question, is there any relation between the degree of humeral torsion and the risk of injury? Good
question. I'm not sure. Paul, I'm going to put Paul on the spot, but Paul, I know you mentioned something about humeral torsion in the journal club that we did this past weekend. Do you have anything, even if you just chime in the chat? I don't know if it's a risk factor. What I know about humeral torsion is that it happens as an adaptive response.
Yeah, I haven't seen anything that shows that it's linked to any kind of correlation even with increased risk. It's just something that has occurred depending upon, and like what Sam said, kind of almost the age at which you start some of those activities. If you start like the overhead throwing and that stuff later, you tend not to develop the same level of torsion. So it's kind of that at your adaptive phases of growth, if you're putting the trabeculi on that rotational stress, you get an adaptation because you're telling your body that you want it to turn that way.
Right, exactly. Probably similar to what we see with hockey, and Derek would be able to speak to the version in the hips that can occur, in youth hockey players. Now, does that lead to stuff down the line? I think is the question. That maybe, but again, what are we going to?
But we don't have anything to show. Right.
It could still be an argument of, well, these 8-year-olds should be doing multiple sports and activities anyway. So But the humeral torsion thing to me is just it's almost an adaptation. It's almost a favorable adaptation, it seems like, because that's what's kind of contributing to that excessive external rotation where they can really get that whip. Now, does that put somebody at more risk of,
right?
Yeah. Now, are you at more risk of heading into Tommy John surgery because you have that now? So
right.
It's like,
yeah, right. The UCL stuff and all that stuff. I haven't seen anything that shows that the torsion has been directly, linked to any of that kind of stuff. But I mean, it's probably somewhere out there alluded to, but we just don't have enough evidence to show one way or the other what that actually is.
Thanks, Paul. I'll close with just one final thing is, we've talked so much about, we don't know. And it can get, that can be annoying for some people. We all want answers, and it just kind of shows you how the process of science creeps along at its own pace. And you saw even at this paper, they collected data in 2017, 2018, and we're just now talking about the paper in 2020. So that's just kind of the process of these things. There's probably more studies that they would have included in this review, that have come out over the past couple of years. But it's also a good thing that we don't jump to conclusions just yet. We just take little nudges, and we may even take this and just say, you know what? I'm hearing all this information. I'm looking at these studies, but it's not enough to move the needle for me to change what I'm doing clinically. But I now know that it's on my radar. So I'm going to continue, if the aggregate of evidence kind of piles onto, and we just say, you know what, that ER-IR ratio, that's got some strong evidence behind it. There's been 3 or 4 systematic reviews now, and it just seems like there's something to that. And you start to shift, but that's just a slow process. And it's 'tis the nature of these things. But I think I'll end on that. Well, Derek's got another question. Go ahead.
Yeah. So my question is, do you think that we contribute to the problem as MSK health providers? Not necessarily saying like this group, but kind of with our overemphasis on stretching and some of these risk factors. Like, do you think that we contribute to some of these problems? It's
possible. Like that exercise program, you could probably put a narrative to each one of those little exercises, right? Like the sleeper stretch, you could say, well, that every time you throw, 50 pitches, you lose internal rotations. Just imagine every single practice over the course of the entire season, like how much range of motion your shoulder is going to lose. Like, obviously that's going to increase our risk. So we need to do this. You could frame it that way. And you could take every one of those exercises and probably say something similar, or you could say, this program is just going to generally get everything moving. It's just going to generally add some load to these areas. It's going to give you some different stuff that you haven't been getting in practice. And it just fills a lot of gaps. So it just checks a lot of boxes for us. It's just going to give you a nice little base. And you could leave it at that, because that's pretty much what we know about it. And then I don't think there would be a whole lot of negative to it, but I also don't think that's the way it's framed, most likely. So to your question, if I had to guess, I would say that there could possibly be some negative contribution. But at the same time, do we not look for risk factors like within us? So I'm not noceboing any of the patients right now. I feel comfortable talking to you guys about this, but the way that I talk to this group about these things is probably different than how I frame it to the athlete. And so if we can try to kind of compartmentalize clinician, we know pain and injury happen. We know that I don't want them to be hurt or get injured, but I also want to foster all of the positive non-specific effects that I possibly can over here and take the pieces that I think can help and supplement. It's a delicate balance and process that I certainly mess up on all the time. But what do you think?
I mean, I haven't had as much experience as you. I know in undergrad as an AT, when I worked with baseball players, there was an overemphasis to almost protect our pitchers as opposed to other athletes on the team. Once a week, we did range of motion checks on them. Every time after practice, it was they had to come in and see us and get ice and make sure that they're doing okay. So it wasn't necessarily like I would say, the language at times, but it was more that we kind of fed into that narrative that, you need to protect your arm, as opposed to other kids who are, practicing just as much, throwing quite a bit, who may still also be dealing with some lingering issues, but instead we're focused more on the pitchers who already kind of view their arm as fragile and needs protected. So, not that I'm saying that if you have, this amount of internal external rotation that your arm's going to fall off, but just that, we kind of were babying them along as opposed to the other players were just kind of, doing whatever they needed to.
Well, and also, like, what if one of those kids had to leave practice early, but so they didn't get to ice? And they're like, oh shit, like, I didn't ice today. Like, I'm not going to be recovered when I have to pitch again in 3 or 4 days. So I'll have a quick turnaround. I didn't get to ice right after practice. So I can totally see that. Like, we talked in the forum about identifying yellow flags and trying to tease those individuals out. And that comes with its own set of problems, right? Like treating people differently. Like, would we frame our words differently for people if they, score differently on a yellow flag assessment or something like that? But in general, I think as a whole, it is possible to take this type of information and spin it into a positive. Like, we have the opportunity to do some good. This is me talking to whoever athlete. We have an opportunity here to, get things strong, keep things moving. You can frame it in a way that's not so focused on the downside, but you're still ticking off the same box. It's a good question, though. Well, Alex has got one.
He says, any specific example of how you would change your dialogue with an athlete versus a fellow clinician?
Well, I think even just the way that we talk in this meeting, like I said the word risk factor 1,000 times, and I don't know, can't remember the last time I said the word risk factor to a patient in the clinic. Like, just these little things, I usually in the clinic, I'm talking about just variables in life that can add up for good or for bad. And I'll give them, examples that tend to be obvious for anybody. Let's just say, you weren't sleeping well, you were underfed, you had stress at work, and you're trying to go really hard in the gym. Like, you would agree that it's possible you might, have a downturn, right? And those things can affect, stress is stress, and those things can affect, what we're trying to do downstream. And for us, it's like, okay, specifically ER-IR ratio as a risk factor for injury. So I think it's just more didactic with you guys, and it's more, let's find a level playing field with the person. So I'm not going to necessarily say life is all sunshine and rainbows, but I'm going to try to find a common ground that we can all agree on, that there are lots of factors that can affect things, negative and positive. And now we have an opportunity to start ticking off a lot of these boxes to gain momentum the other way. So in the same way that all these factors can aggregate, moderate, and work against us, we can start to change those things and they can be working for us. And that's when you start getting into then, what does that look like? This is a good place to start. Like, what's the lowest hanging fruit? I'll use the word, here's our entry point. I'll say that with you guys, but I'll also say that in the clinic. So we're saying similar things, but it's just framed differently in that way. I don't know if that answers your question, Alex, but.
No, it does. Thank you.
Yeah, man. Cool. All right. I was afraid about this one. I wasn't sure how much we were going to be able to get out of this paper, but this is a really good conversation. And like I said, like, this is one of those papers that you can just keep in your back pocket, even as just a reference. It's like, oh, what are those papers? What's the evidence on, ER strength for pitchers? Here you got, aggregated review for you. So we'll be banging these out weekly, I think, hopefully. Megan just put a post-meeting survey in the chat. Open that up before we close out so that it doesn't, you don't lose it. And then give us feedback. and we will be back next time. We'll shoot some topics in the forum, and then we'll be back. So thanks, everyone.